being here, and I'm excited to hear your talk.
Thank you very much, Will, for the very kind introduction. And I always enjoy coming to NCSGI when invited. It's a great chance to get to see colleagues nearby. We work with each other, but usually via email or phone call and don't get to meet. So I am charged to talk about nuke therapy for Hep B, to stop or not to stop. Okay, so now this has become a bit of like a hot topic or a fashionable topic in the recent years because of the HBV cure efforts with a lot of clinical trials going, and people wanted the question, you know, before we get the cure therapy, can we do something more with the current therapy? So I would like to review briefly the goals of nuke therapy and the current guidelines for stopping, and then review with you the current data on finite nuke therapy stop, or what are the pros and cons for keep on going indefinite therapy. So let's start with a case study. This is a real case that I saw several years ago. 58-year-old woman, native of Korea, presented with newly diagnosed hepatitis B. So right here, we already see that there's something wrong with this picture, right? This person probably have had Hep B most of her life or all of her life, but she only got diagnosed at 58. So, you know, consistent with what we know of only about 20% of Hep B in the US have been diagnosed, and globally, the WHO estimates that only about 10% have been diagnosed. And the patient have no symptomatic complaints at all. It's just purely somebody remember and screen her. And again, this is why we call Hep B is a silent killer, because people usually find until they have end stage cirrhosis or liver cancer. She's pretty healthy, just takes like lisinopril, high blood pressure. She's pre-diabetic, but doesn't take any medication. She has a brother with Hep B, but no family HCC. And this is important because family history of HCC is well known to be a major risk factor for HCC in a given individual. She's married, husband and son are immune for Hep B. That's important. We need to make sure household contacts are immune either by prior exposure or they need a vaccine. She drinks alcohol socially, doesn't smoke. Exam is pretty unremarkable. BMI is 25, which is remarkable. And I wanted to remind ourselves here is that BMI is a cutoff for overweight for non-Asian, but for Asian, the cutoff for BMI for overweight is 23. And depending on who you read, cutoff of 25 to 27 would be for obesity. And the reason for this lower threshold recommendation by the WHO several years ago is because the complications of metabolic diseases in Asians starts at cutoff of BMI 23. So, and this is actually something very hard to tell patients. Patients would say, really, I'm overweight, I'm obese, you know, and when they're walking around, many people don't think so. And some of the reason is because of the fat distribution, the pear shape, the visceral fat distribution in Asian. So the lab data is pretty unremarkable overall here. CBC all normal. There's no signs of portal hypertension on that. Synthetic function is great. INR is normal, same as TBL and albumin. ALT at 35. So this one is something to mention because the cutoff for normal ALT is up to like 40 or 60, depending on the different reference lab, but very good data almost 20 years ago now from Italy show clearly that in people who are truly healthy with no metabolic diseases and no significant alcohol, the healthy normal ALT is 19 for women and 30 for men. Few years ago, the AASLD kind of adjusted up a little bit to 25 as normal for women and 35 for male, sort of like adjusting for the fact that, you know, it's probably almost impossible to find many adults without any metabolic diseases at all, quoting the same study actually. The patient is surface antigen positive, E negative, DNA is 75,000. So quite typical for an E negative patients. We don't have billions or millions of DNA viral load with E negative. Her Hep C antibody is negative. And that's important because even though Hep B is much more common in Korea, Hep C also can be common too. And Hep D is a co-infection with Hep B. So that should be tested in all Hep B patients. And in fact, we hear about Hep C disease from Western Europe and the US because that's where all the pivotal clinical trials were conducted. But the major reservoir, the vast majority of the reservoir of hepatitis C in the world is actually not here, but in East Asia. Liver ultrasound is unremarkable. Patient decline biopsy. Most patients would. And fibroscan was not done and has not been done because of the high copay by her insurance. So very briefly here, I think that we all know the cutoff for non-cirrhotic E negative patient for treatment is 2,000 for Hep B DNA threshold. And then next to it is ALT. If ALT is totally normal, less than 25 for women, less than 35 for male, then we monitor. And if it's more than 2 times, so in this case, 50 for this woman, then the recommendation is to treat. But then there's a big gray zone, okay? About 50% of Hep B patients are in the gray zone in the middle here, where ALT is elevated, but not quite 2 times. And DNA sometimes is not more than 2,000, like 1 to 2,000. So what do we do? So there are a lot of fine prints in the guidelines that we may or may not pay attention to when we go through it. But in general, the recommendation is to treat if ALT remains elevated, or if the patient is older than 40, or if we know the patient has F2 fibrosis or more. So this patient, because of her age, it is elevated, and her ethnicity, she most likely have had this for more than 50 years. So the decision was to treat the patient. 9 months later, DNA became undetectable as expected because her viral load was pretty low to start with. 18 months later, ALT became normal, 22. So we know for this lady, normal was not 30 like earlier. And 5 years later, the patient asked, can I stop treatment? I've been negative for 4 years now, somewhat. So what should I do? So this is not an uncommon question for many patients, as you probably have already encountered a lot in your practice. So let's review the goals of treatment and guidelines for stopping from the different society. And this is part of the problem, with our field. We have so many guidelines, and guidelines generally agree on the main principles, but the exact where to cut off and stuff like that tend to differ and make it very complicated and make it difficult for the clinicians and patients alike. So the short-term goal, okay. So 10 years ago, people talked a lot about short-term goal, about viral suppression, ALT normalization, and also viral resistance, because we did not have very good drugs, lamivudine, tabivudine, adefovir, a lot of toxicity, a lot of viral resistance and low potency. But the current first line, entecavir and tenofovir, these are not the problems in almost all patients. Very rare you would have an E positive with billions of DNA that you may have to add a second agent to. But the vast majority, no problem with viral suppression and eventually ALT normalization. And then for E positive, then we want to see E seroconversion, within a few years of treatment. And for patients with cirrhosis or impaired liver function, we would want to see improvement of the liver function. Nowadays, we focus more on long-term outcome. So we want to see lower HCC incidence. We want to see decrease in fibrosis progression, and we want to see regression of fibrosis. So these are what we see. And there's a lot of data, both real world data and in clinical trials, to show that these do happen with long-term treatment. And ultimately, we want Hep B SAG seroclearance, what we call functional cure. And why are we not just calling it cure? Why is it functional cure? Because it's not truly a cure, because these patients still have cccDNA in their liver. So it's not sterilizing cure. So these patients can still reactivate. They would be core antibody positive, and they can reactivate spontaneously in very rare cases or in the setting of biologic or immunosuppression. So functional cure, what is it really worth? Is it really worth it? And how common, how often can we achieve it? So medical benefits is, I think, well known to most people, lower risk of ACC. So just imagine if you have suppressed virus and you still have more risk of liver cancer than someone who clears SAG. Now you can make the extrapolation to see if someone who have low viral load, would they have higher risk of ACC compared to someone who is completely suppressed? So that would be something that has not really been shown, because it's very difficult to show. The risk is quite low in both groups, so you would need 10,000 patients to show that. Benefits for medical reason is finite course, decrease in the transmission, and lower risk of reactivation, not zero risk, but lower risk. Now, the more non-medical benefit of HBV cure is something people don't always talk about, but I think we need to be cognizant of it, because in our society, you know, we are lucky to live in the US where there are laws against, you know, overt discrimination. But in many areas, like, you know, in East Asia, many places, people cannot get a job. People would be isolated or discriminated against if they are known to have Hep B. So that is part of the reason why the diagnosis rate is so low in many places. People don't want to know. It's like no ass, no tail. Now, unfortunately, surface antigen seroclearance is a very difficult goal. Okay, this is a large meta-analysis from 40 studies and 40,000 patients of treated and untreated patients. So it's pretty mixed, okay? So existing literature usually included mixed population or just untreated, very few treated. And in here, the rate of seroclearance is only about 1% or so. So it's pretty low. But I suspect that among the treated population, it is lower, because you may think that they are treated, so their clearance should be higher, but actually not, because we can see that in our practice, we don't see 1% of the patients seroclear in 5 years, because these are older and sicker patients. So we looked at two separate populations. So one is untreated patients, and they are untreated for reasons. In some places, they don't get treatment because there are no means for it, but a lot of times it's mainly because they are not as sick. So we found a higher rate of seroclearance. So spontaneous clearance in untreated patients is about 1.33% per year. Now, when we look at the treated patients, it's much worse. 10-year cumulative rate is only about 2%. So only about 0.2% per year in the treated populations. And this cohort come from the US as well as Asia and from Europe. And we also see that it's linear. So it doesn't get better as time goes on. So it seems to be kind of trotting along 0.2% per year. So it's very rare. And that leads to the current guidelines for stopping. And you could see, I bolded in green, many of these ask for SAG loss before we can consider stopping. Okay, and we already know that treated patients is very rare. So in reality, most of the time, we don't have the luxury of even considering this, but that doesn't mean that we should not consider it at all in appropriate cases. So in e antigen positive patients, the prerequisite is e antigen seroconversion. And this also is much easier to get than SAG seroclearance, but still not that high, 15-20% in the first few years for E-positive patients. The AASLD recommend that after we consolidate for 1 year, and if the patient is not cirrhotic, then we can consider. So very important. If the patient is cirrhotic, we don't stop, because when they relapse, they can really get a bad flare and they can decompensate and can die from it. So we don't touch the cirrhotic patients. And alternatively, we can treat until SAG loss. So usually I give this a patient the choices, and some patients try to stop, and if they relapse and they get treated again, but many of them will just say, you know, why bother, just continue it. EASL, pretty much similar thing, except that they don't recommend to continue until SAG loss, but they also stay away from cirrhotic. Now, AASLD did not mention cirrhosis in here, but I want to point out that the AASLD guideline is a little bit dated. It was published in 2015. That means that the data they reviewed was a few years old, at least by that time. So they probably did not have the benefits of the more recent data in the last 7 years or 10 years. Now for E negative, and E negative is usually the population that we consider stopping, and really the topic in population of the most of the data on stop therapy, because E positive is very difficult to stop in general. And there was already lots of data a long time ago in the people who seroconverted, and we already know they relapsed. So for E negative, the recommendation is to treat indefinitely by the AASLD guideline unless there's a compelling rationale for stopping. And that could be, you know, we don't want patient to go bankrupt, you know, if they cannot continue the prescription, or if they are having a severe side effects or so, which must be very, very, very rare. But they also say to consider treating until SAG loss. And again, SAG loss, we can stop if the patient is not cirrhotic. But if the patient is cirrhotic, then that's different story as well. And the EASL patients here are also pretty similar until SAG loss, and in selected patients if they are not cirrhotic. So pretty consistent. So you can see that there are differences, but the general theme is the same. Stay away from cirrhotic patients, and also SAG loss is probably the end goal in most cases. So why are we talking about pros and cons? Obviously, because there are risks and benefits on both ways. If there's no risk, then we stop everybody already, but there are significant risks of clinical flares and death, including death. And I'll show you more data on this. And on the other end, if there's no benefit of stopping, then, you know, we would not stop, right? Because lots of people, it's not so inconvenient and insurance cover. But the main benefit for stopping is that it may facilitate surface antigen loss. So that can be a real benefit. Functional cure is worth a lot. So it's not to be, considered trivial. So let's go into more details on both of these arms. Okay, so what happened if we continue therapy? What are the up and down sides with this? Okay, so resistance is exceedingly rare now. In the old days, that's not the case. In the old days, 50% resistance after 5 years of lamivudine. But now there's no resistance practically with treatment-naive patients with entecavir and tenofovir and TAF or Viriad. So that's not really an issue now. Long-term safety profile is also quite excellent. There was a study from Hong Kong about 3-4 years ago that they reviewed 52,000 patients on long-term NUC, 5 years at least, in the whole Hong Kong territory, and show that the medications are quite safe. Now the other, so those are the potential downside of continuing the treatment that is probably not really a big issue or significant issues now. What are the potential benefits? Now, continued viral suppression probably would prevent disease progression and lower risk of HCC, and there's lots of data for this. And another downside is that it can be inconvenient for some patient to take a pill a day. Most patients probably do not care, but for some patient, it may be a big deal. So it's an individual consideration. Now, cost. So previously, people talk a lot about cost, why we should not start people on treatment, why we should stop treatment because of cost. Now, I would venture to say that this should really not be a big issue now in most cases, because, you know, in Western countries, it's covered by most insurance with pretty small copay in most cases. And in endemic areas, like in East Asia, in China, for example, where a lot of these patients come from, the cost is very low now for generics, starting about 3-4 years ago. In fact, many doctors there that I work with and patients tell me they can buy entecavir or tenofovir generic for $10 for 3 months. So, so it's, and for China, even people from smaller provinces, it's still affordable, $10 every 3 months. Okay, so that's if we continue. If we stop, what happened? Okay. Now, virological relapse is very often, in fact, almost universal eventually in E-negative patients. So this data is from entecavir patient and stop, and relapse is defined as DNA more than 2,000. So you can see by 36, 38 months here, more than 90% have relapse. And if you consider 1,000 DNA as relapse or less than that, then it's practically 100%. And you could also see that the majority relapse between 3 to 6 months here, but the relapse can delay out a few years. And this is important to remember, because how long do we need to monitor them? You know, 1 month, 1 year intensively, maybe not so bad, but, you know, few years can be quite burdensome. Okay, and then clinical relapse. So virological relapse usually is not going to kill anybody right away. You know, there can be long-term consequences with high viral load with disease progression. But clinical flares, clinical relapse is what we fear, because some of these can lead to liver failure and death, especially in people with F3 or F4 fibrosis. And it's pretty common if you define ALT to be just like 1-2 times upper limit of normal, so about a third here. And these are data for up to 12 months only. So imagine the rate would be much higher if you go out to like 3, 4, 5 years. Now, most of these are subclinical. So, you know, most of these are not going to kill the patients. So I'll show you the data for severe flare later. And then the other important thing to remember is that not all flares are bad. Some actually are good. It can facilitate SAG loss. So, but then how much of this benefit is something that I think is open to interpretation. So I am convinced that some flares are very good and can facilitate SAG, but how often? And this is something is important for us to know and discuss with the patient, because if we tell the patient that the chance for SAG loss is 0.51%, then it's different from if you tell the patient that the chance is 10-20%, right? So let's look at some raw data. So this is a table in a recent NICE review by Thomas Bird group. So you can see in here that the sample size are quite small. So the first column that I highlighted is sample size. Most of the study, half of them only have about 20 patients. So these patients must be quite selected, right? And there are 2 large studies, more than 100 patients there. Both are from China. And the top one reported an SAG loss of 8%. The other one, 0. And the top one includes interferon. And you can see that in many of these studies, interferon was included. So I believe that the higher rate is probably from more selected population and also augmented by interferon. But if we just stop our garden variety patients without interferon augmentation earlier, then I think that the rate would be low, 1% or less. It's not 0, but it's not very high. Okay, now severe flare. So I think most of us would agree that 5 times, 10 times upper limit of normal is clinically significant flare. And fortunately, it's rare in non-cirrhotic patients, but it's not zero. The vast majority of the decompensation and death occur in people with F3, F4, and it's about 1% over 5 years from most studies. So it's very important to monitor and identify these early so that we can retreat the patient. But another very important thing to remember is, as with the chemo-induced reactivation, retreatment does not guarantee that you can reverse or halt the current liver failure and prevent death. So the data that you may hear around usually are from a very specialized group and monitor their patient very intensely, and the patient is probably very motivated. So the rate may be lower than real world. So more recent real world data, and the top one I'm showing you here is from either university in Taiwan. So it's still a university practice, but you already can see a higher rate of death here, 0.36%, despite retreatment. So it's not very high, right? But it's finite. And this is in people who are walking around asymptomatic and normally should not expect to die at all, in the next 3 to 5 years. So it's a small number, but it's a finite number, and we have to take it seriously. Now, how about looking at larger population-based data? So the Taiwan National Insurance Database includes like 99% of the population, like what you may see in the Scandinavian countries. They have a few million people, and in Taiwan, 23 million. So they can put everybody in one single database. So they selected these Hep B treated patients for people without major comorbidities, people who've gotten either entecavir or tenofovir for at least 1 year, and they follow these patients. And the characteristics here are fairly typical for what you expect of a Hep B cohort in general, and cirrhosis is about 10%. If you go to university, probably 20–30% are cirrhotic, but in here about 10%. And here's the data. So the severe flare rate is about 6% over 4 years. And mortality, people actually die, is about 0.6%. So small number, not huge, but it's not zero. Okay. So an associated risk factor. So what can we do to identify who are high risk, low risk for the flare? So cirrhosis, advanced fibrosis, we mentioned again and again already. Other risk factors are older age and male compared to female. This is for flare, and fairly similar for mortality, as well as if we consider transplant as another outcome. So the bottom line here is that it's probably no to little harm or inconvenience to continuing NUC in most cases. Cost is a separate issue, and this really depends on the patient, their insurance, and their setting. But stopping NUC is definitely an option for non-cirrhotic, extremely compliant, extremely motivated patients. There are real benefits of cost savings and, very importantly, potential for SAG clearance, functional cure, the very highly desirable goal. But how much is this chance is something that is not clear, and is probably not very high. And what are the risks of stopping? We may risk progression of cirrhosis and higher risk of ACC versus keeping the patient suppressed with continued treatment, and the small but finite risk of liver failure and death. So it's really a matter of choice. Which way is this? Risk versus benefit. Sometimes the risk and benefit may seem to be similar, but usually in life it's usually not balanced like that. And the risk is usually higher or lower in individual patients. And maybe sometimes the risk and benefits may be, if you look at it from data, may look the same, but the risk tolerance in different patients and different doctors are the same. It's just the same way as how people want to invest their money in the stock market. So there are different risk thresholds in this. So we really need to discuss with the patient. Now, there are some risk scores to help us predict patients other than just knowing that higher risk in male and cirrhosis. So this is one of the more known scores, also developed from a cohort in Taiwan. and has been externally validated by the group from Europe. So it seems like it may be useful here, but it requires quantitative surface antigen, which is available now in the US in the last few years, and correlated Hep B antigen. And this is not widely available yet in the US. So usually we would not be able to use this here, at least for now, but hopefully in the near future, we can have that. So I put this up again so that we can digest it a little bit again. So a lot of these call for surface antigen loss, which we know will be difficult to get. And we need to have compliant, and we need to be certain the patient is not cirrhotic, because we have seen the data. The risk of fatality is quite significant if the patient is cirrhotic. So that is really important. And this is one algorithm that I find to be quite clear and useful by Thomas Berg, one of the investigators in this field. So you can see very top cirrhosis. So you have to be certain if the patient have no cirrhosis. And then, you know, you can go down to suppression for at least 4 years. And then quantitative surface antigen has to be less than 1,000. And then they have to be guaranteed. You can see the word, you know, we rarely see the word guarantee in algorithm or in medical writing, but, you know, I could understand why they put this in, guarantee for close follow-up over 12 months. So that is very important to take notes here. Okay, so back to the case. So I had, you know, the discussion with the patient and asked her, you know, give her, you know, the information that I just presented to you, you know, in, you know, a shorter fashion without graph, but, you know, just tell her what are the pros and cons in there. So she's now 63 because she was 58 when she started. Now she's 63. So also remember, if we monitor the patient does get older as we monitor them too. She decided to just continue because it doesn't bother her. She has no side effects from it, and her copay very low, so it doesn't bother her. And she doesn't really want the intensive monitoring. So there's really no guideline on how often we should monitor these patients. But for me, you know, I probably do like every month in the first 6 months and every 3 months for another year, and then, you know, every 6 months. So for many patients, that's too much. And I would like to also share that the data that I show you, the investigator monitor the patient much more rigorously than every month. One of the biggest investigator in this topic is Rachel Chen from Taiwan. Their protocol monitor the patient every week for the first few months, and then every 2 weeks. Is, you know, it's quite incredible. Even in the clinical trial, it's very hard to get patients to do that. And then she just doesn't want to take the risk of, you know, potentially ending up in the hospital, get sick, or even dying from it, even though the risk I quoted her is very small, because she feels fine now. You know, why would she take the risk of possibly becoming sick or dying? So my conclusion on this is that I think it's risk versus benefits, that we need to talk to the patient realistically on a practical level. Is the chance for SAG clearance worth it for this patient? If the patient is 80 years old, maybe it's not so worth it. The patient has been doing fine with whatever. But if the patient is 20 years old and he, you know, and it may be worth it. And if the patient really wants it, then, you know, and also a 20-year-old is a lot less likely to have cirrhosis too. So the risk is probably lower. Now, the second thing is, are we sure the patient have no cirrhosis? And I would admit that there are a number of my patients, and, you know, I see, you know, in my clinics that I have all the data available to me, except a liver biopsy. And I am not totally sure the patient have cirrhosis, because FibroScan say it's okay, you know, only 656 kPa. FibroSure also doesn't say F4, but, you know, the platelets on the low side, you know, the patient has some pulmonary edema. I just don't feel totally comfortable. And we use FibroScan, and a lot of time we think it's so great, and it is great, but just remember that accuracy of FibroScan is only about 75%. It's actually not any better than FIB4 or FibroSure blood test that we can do, but it's just a bit more fashionable to do FibroScan. But many studies have shown that the FibroScan is actually not better than the FIB4 that we can calculate for free from the patient's routine labs. And we can classify the patient 25% on average. So just think about it. That's not a trivial percentage to be wrong. Now, MR elastography is much better. Accuracy is coded at 90% for most studies, but again, it's also not 100%. And it can be both ways. I have had patients who's on my transplant list, and they get MRI for other reasons, and the elastography was done as part of, the MRI at Stanford. And sometimes they would tell me the patient has stage 2 to 3. Of course, I don't pay attention to it, but it just reminds us that none of these tests are perfect. So we need to know if our pre-test probability was low for cirrhosis and a good test is negative, then maybe the patient is not cirrhotic. But if our pre-test, our clinical impression is that the patient may have advanced fibrosis, then, a negative FibroScan may not be good enough to rule out cirrhosis for an important decision such as this. And then is a patient guaranteed to monitor intensively for 12 months and regularly for 3-5 years after that. And then we also need to ask, does continuing NUC cause any significant medical, social, or financial harm or inconvenience for the patient? And are we committed to monitor the patient intensively? So if the patient falls off the radar and don't come back for their 3rd month check, do we have a recon system to identify that and call the patients? Usually, we only see the lab results or the patients when they come to our clinic or when it comes to our inbox. But if the patient doesn't show up for lab and doesn't show up to clinic, we may not know unless we have a recall system. So everybody has to be committed. It is possible, and it may be worth it in some cases, but I think it has to be a very well thought out decision and taken seriously by both patient and doctor. So I think with that, I would like to end, and I would be very glad to take any questions. Thank you for your attention.
Well, thank you, Mindie. That was dialed right into some of the stuff that I've been thinking about. So that was just such high yield talk. I don't see any questions in the chat yet, but I have several. So I'll just try to see if anyone else has any so I don't take up all the time. So my first one is, I was compelled by the quantitative surface antigen as a predictor of, I think, clearance that you said. So we have that available too. It's not quite standard in any way, but do you use that?
Yeah, we use that, but usually the literature use IU, per ml units. At Stanford, they report it as an index, but Quest use the IU. So usually I actually order the lab to send out to Quest. So is at Sutter you have IU or you have the index? I
believe it's IU.
IU, mm-hmm. Yeah. So you can use a literature because they are based on that. Mm-hmm.
I've had a couple of patients recently where I've really been up against this question, and it was really helpful to hear age as a major factor in making this decision. Does the clinical profile before treatment, when they say they're e antigen positive, does that have any bearing? Some people come in with very high transaminases, and some people you kind of wonder why they were treated at all. Is there anything that ever shows that their prior immune reaction to the initial virus might predict anything after withdrawal?
That is a great question. But as I mentioned, most of these STOP studies are on E-negative patients, not E-positive. So usually E-negative, as you know, the DNA level is not very high, and usually the ALT is not very high either, usually more like between 50 to 100. Mm-hmm. And I have not recalled seeing any of those as a baseline. But, in the scale B, they did have ALT as one of the predictor. So I suspect that it does have some effect in it. How big, not very clear, but it seems like, the biggest effect. So the scale B is to predict the relapse. Yeah, so it does correlate. Mhm.
And then I'll go ahead and ask my last question. This might be getting a little bit away from the topic, but I wondered if you had any thoughts on how we should be thinking of the so-called incomplete seroconversion or the double negatives, where they're e antigen negative. They clear their e antigen, they never make e antibody, and they're like that long term. I don't know that I would withdraw treatment in those patients, but are there other things that you're thinking when you're seeing those patients, or do you just treat them like another e antigen negative patient?
Good questions. Yeah, I also recall a few. So far, I just treat them like anyone else. For E positive patient, the prerequisite from all the guidelines is seroconversion. Yeah, so at least for E positive, it's pretty clear. The E negative is the one that has been difficult. But your question is so is the E negative, is it truly E, E negative that they clear, or did they over time develop mutation and become an E negative patient? I don't think we would really know until we stop treatment and see how they behave after that.
Yeah.
Yeah. Mm-hmm.
Okay. Thank you.
Thank you.
Oh, quick
sorry.
question. One of the ID attendings recently mentioned to me that she has her HIV and Hep B co-infected patients on dual antiviral therapy.
Mm-hmm.
I couldn't really find any literature to support or refute that. Can you comment on that?
Okay. Mm-hmm. So that is the standard practice. Yeah, it's on dual. So I don't recall off the top of my head, and I guess I myself have not questioned that and just kind of follow it. And while you mentioned that, I wanted to also mention that if they are HIV and Hep B co-infected with Hep C, and if we treat them with DAA, then the recommendation is that they even want a third one on board during the treatment because of the breakthrough. So there must be some interaction in there, because I think that, that with Hep B and Hep C, usually one dominate. So they probably worry that as they suppress one virus, the other one may become more dominant, and therefore they need to control it better. So I'm just suspecting that, but I have not really looked into that deeply myself on that topic. Thank you.
Sorry, I was falling down to my duties as the moderator. There are questions now, so we'll take a couple more minutes. Thank you, Dr. Nguyen.
Yeah.
So there's a question here about, let's make sure I go to the beginning. You talked about FibroScan, even MRE. How sure are you about cirrhosis? There's a question here about, is ultrasound alone good enough for you to say this patient is not cirrhotic? Morphologic features like nodular liver, things like that.
Yeah, that's a good question. Many patients as well as practitioners often say, my ultrasound doesn't say I have cirrhosis, so I must be okay. So the morphologic characteristics of cirrhosis on imaging is a nodular surface of the liver, a shrunken liver, or hypertrophy of the left lobe, and other indirect evidence of varices in the abdomen. So the ultrasound is quite insensitive to all of this. The ultrasound would not see varices, it's not very sensitive to see the nodular liver or even the left lobe hypertrophy. So if they show it, it's probably there. But if they don't show it, then you cannot say the patient is not cirrhotic. Now, if we want to check for morphologic evidence of cirrhosis, MRI would be much better. But MRI is not 100% either, because early cirrhosis the surface may be very minimally nodular and may not be picked up by MRI. And a well-compensated cirrhotic patients can have completely normal liver function and CBC if they have no portal hypertension, if they have no hepatic insufficiency. So well-compensated early cirrhosis are quite difficult to diagnose.
Thank you. And there's two more, and I think these are good questions. So there is a question about lamivudine, and I've often wondered this myself. Patient completely suppressed long-term lamivudine, normal enzymes, no concern for any disease recurrence at all, no known history of resistance. Do you watch them on lamivudine? How hard do you push to switch them?
That's a great question. And I had to deal with this 1-2 times myself. So of course, nowadays, we would not start anybody on lamivudine. If a patient's been on lamivudine for 5 years or less, I probably would push hard to switch them so I don't have to worry about it anymore. But I've had patients who's been on lamivudine for like 15, 20 years, and they are fine. So I discussed with this patient and told him that you probably fine, you can continue or you can switch. There's no harm in switching, just in case, even though you may be okay with lamivudine. So this patient actually stayed on lamivudine for several years. And then one day he just say, oh, I just go to entecavir, to not have to worry about it ever again.
Outstanding, thank you. And I'm going to paraphrase this one as well. So this is a 65-year-old Asian patient, previously antigen negative, treated and cleared surface antigen, has a family history of liver cancer. The patient is not cirrhotic, has a positive surface antibody as well. And I'm getting some information about a FIB4 and things that are reassuring. Can that patient come off of therapy? And if so, when?
Yeah. So, and I assume the patient only seroclearance maybe recently, in his 60s.
I think, well, I don't know, but let's say recently, or this 5 years, maybe that was 5 years ago.
Okay, yeah. So in this patient, if you are very confident the patient has no F3 or F4, I think the patient should be offered to stop. And I have offered to stop these patients in my practice. But I had told the patient that, we still need to monitor you for relapse. So I would do every 3 months for the first year, and then, every 6 months for 2-3 years, because in the first few years, we know that people can revert back and forth a little bit. But one thing that I would stress to the patient is that if they seroconverted after like about mid-40s, I would tell them that their risk of HCC may remain significant because of their older age as seroclearance. So I would still recommend that HCC surveillance continue, even if we stop your medicine. If they clear in their 30s, then they are fine. I would tell them that, I monitor you for a few years, and then after that, you don't need to see me again.
That's a very helpful answer. Thank you. And that was all.
Thank you very much.